I'm Philip Soplinski Jr., MD. I'll be discussing black and white and gray secrets of the trauma chest x-ray. So first we'll discuss some normal anatomy of the chest on a chest x-ray. Starting from midline, you have the trachea here, the aortic knob, you have the right main pulmonary artery and the descending thoracic aorta. You have the heart here with the left and right ventricle and left and right atrium. You have bilateral diaphragm, stomach bubble, and then up here you have the clavicles working out from the midline to lateral, and then each individual rib coming from midline to lateral. And then on certain chest x-rays, if you're able, you'll be able to see the humerus and the shoulder and possibly the scapula. And then down here, this dense portion is the liver. Then this is a lateral chest x-ray. Starting from the top here, we have the patient's right arm is raised above their head. That's their humerus. Midline here, you have the trachea. Then the vertebrae with the scapular blades, the ascending aorta. You have the heart here with the right and left ventricle. You have the diaphragm and the posterior costophrenic angle. First, we'll discuss the quality of a chest x-ray. When you get a chest x-ray, first you have to make sure you have the right patient, what their age and sex is, and understand the history of the patient and why you're getting the chest x-ray. You want to identify the projection and technique used, whether it's an AP, PA, lateral, portable, or standard distance, and we'll discuss that more in the coming slides. The position of the patient, whether they're upright or supine, which we'll also discuss, whether it's decubitous or lordotic possibly, and then look at the inspiratory effort. This will go into further also, whether it's adequate, hypoinflated, or hyperinflated. So x-ray basics, the 5 basic radiographic densities. When you're looking at a chest x-ray, in particular, on a chest x-ray you'll be able to see air, fat, soft tissue, bone, and metal in contrast. So first, air attenuates very little of the x-ray beam. Attenuation of the beam essentially means whether or not it's absorbed or diffracted back towards the source, or whether it's absorbed by the cassette. So air will allow the beam to go through completely. So in the chest here, in between the ribs, you see that it's a little darker, so it attenuates very little of the x-ray beam. Fat and soft tissue attenuates intermediately, and you get shades of gray. So in the breast here, in the axilla, it looks more gray than it does white. Bone, metal, and radiographic contrast attenuate white on radiographs, so you can see that most particularly here in the vertebrae, they absorb most of the x-ray beam that comes in or diffracts it back, and that allows it to look more white. And then thick versus thin structures. So if you compare the rib versus the vertebrae, the rib is relatively thin compared to the vertebrae. So if you look, the vertebrae is more white, the ribs are more gray. So proper technique, 4 basic features of the technique. You want to look at penetration, rotation, inspiration, or motion. So penetration is whether or not you are able to penetrate into the person adequately. You'll see here that there are faint intervertebral disc spaces of the thoracic spine and branching vessels seen throughout the cardiac shadow and the diaphragm. That shows that you had adequate penetration of the x-ray. Rotation, whether or not the x-rays are meeting the individual straight on, and usually you can tell by the sternum meeting right over the vertebrae and whether or not there's a vertical line that can be seen with the trachea. And then inspiration, did the patient take an adequate deep breath when the x-ray was taken? In particular, if you look on the right-hand side of the patient, you want the right hemidiaphragm below the 10th posterior rib. Motion, whether or not the person actually moved. If you look at the difference between the A and B, the top one here is a traditional chest x-ray. The bottom one in B is actually a rib x-ray, and there's a reason why we get this sometimes. So with motion, you can see that you want adequate cardiac margin. You want to be able to see the diaphragm and pulmonary vessels, and they should be sharply marginated. AP versus PA. So the most common one that we get in the hospital is the AP. It's essentially a flashlight flashing down x-rays onto a cartridge that then captures the x-rays. And this beam here scatters slightly out as it goes over 6 feet down to the plate. And that oftentimes will cause some issues that we'll talk about later with magnification within the chest. PA, sometimes we can get this, but as you can see, the patient has to be standing. In particular for trauma, it'd be very difficult to get that as opposed to getting one while the patient is laying in the bed. So with the PA, the X-ray beams are coming in parallel to the patient, and there's no spreading of the beam, or at least minimal, and that would allow you to not have quite as much magnification on the X-ray. Upright versus flat. So PA versus AP, supine and upright. The effect of the position of the chest X-ray, PA, you can get a fuller inspiration of the patient. You can see the thoracic contents better. On the AP supine view, sometimes you'll have issues with abdominal contents being pushed up, or the hemidiaphragm moving upwards, or the chest might appear hypoinflated, particularly for patients that can't take a deep breath with rib fractures. And also it ends up with the magnification of the heart relative to the PA. And that has to do with that flashlight effect where you're closer or farther away from the flashlight. When you look at the shadow on the wall, it'll make you look larger, and that's basically how the heart can look larger on a chest X-ray than on the AP versus the PA. Magnification, we just talked about that. On the AP, the heart is farther from the detector. The X-ray beam diverges as it goes farther from the tube. On the AP, the beams are hitting it dead on, and these are the same person. You can see the difference between the heart being slightly magnified based on the divergence of the beam. Exposure. We have packs nowadays. We can attenuate the exposure a little bit to be able to see different things. Overexposure, underexposure is not necessarily good or bad. It's what you're looking for. So overexposure, you can see behind the heart in the regions of the clavicle and thoracic spine. You can see the ribs a little bit better, and it's not obscured by the pulmonary vascularity. When you do the underexposure, it attenuates the pulmonary vascularity, but then you can't see behind the heart and behind the hemidiaphragm for fractures of the posterior ribs. So both have their purpose. They're not necessarily good or bad, but you have to know what you're looking at. Expansion. Whether or not the patient took a deep enough breath, very rarely would we take a chest X-ray where there would be expiration. Normally you want inspiration, and like I said previously, you want to be able to see on the right-hand side about 10 ribs, maybe the 11th rib if you can capture it, with a deep breath, and that'll allow you to be able to see the contents of the thoracic cavity better. The problem ends up with expiration that the thoracic contents will be squished down within the thorax, and it may make it appear that you have infiltrates or some other breast shadow that might overlap, that maybe you're getting skin folds that might make it look like you have a fracture of the rib. Chest X-ray versus rib series, both of these have a purpose also. Normal chest X-ray, you'll have a relatively high voltage, allows for visualization of the heart, pulmonary vessels, and skeletal structures. A rib series, this is when you would suspect that the patient has some sort of rib fracture, maybe on your physical exam. They lower the voltage of the beam, and that allows for the pulmonary vessels to become harder to see, but then the bones become easier to see. So when you're reading a chest X-ray, normally you want to work from the midline to lateral. You want to identify the structures that you're looking at, organs, vessels, infiltrates. You want to look at the bones moving from medial to lateral. You want to look at the hemidiaphragm and the costophrenic angles. You want to look at the clavicles going from median to lateral. And then if you can take a look at the apices. And then sometimes you can see the humerus and the shoulder and the scapula possibly. You want to look at the airway and see if there's tracheal deviation from the midline. Lung symmetry, is there any mediastinal shift here? Is there lung infiltrates, masses, or nodules? You want to look for fractures, and if you have tube placement, you want to make sure that it's adequately placed within the chest and that it's above the carina, and we'll discuss that more in the part 2 of the chest X-ray. Then once you've done your read, moving from median to lateral and identifying all of your structures each time, you want to look then behind the heart. Look behind the diaphragms. You want to look at the lung apices. You want to see, is there a pneumothorax that's obvious? You want to look at the chest walls. You want to look for lytic lesions or fractures again. Look at the shoulders if they're apparent and look at them bilaterally. And then the most important thing is you probably want to take a look and see, are there old images for this patient? Maybe some of these things that you're seeing were already there. And for a trauma X-ray, you want to know what's new, what needs to be treated immediately. And that's the beginning of how you take a look at a chest X-ray. We'll have part 2 that will explain more on some of these things and what they are and how to identify them.